Hello, and thank you everyone for joining us today for the presentation titled CCBHCs in Strengthening Crisis Care. Before we begin, we would like to remind you all that this is a safe and friendly space for positivity and productivity. There are a few housekeeping items I'd like to quickly go over. This presentation is being recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. This information will also be available on the National Council's website and NASHBI's YouTube channel. Please use the chat pod to share your name and state, ask questions, and/or share information with the group that pertains to the presentation. Closed captioning can be viewed by clicking the CC at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who is spotlit on your screen. When the presentation ends and you leave the meeting, a brief survey will show in your browser. Please take a few minutes to share your comments and thoughts about today's presentation. We would like to give a special thanks to SAMHSA for sponsoring this presentation, and thank you all again for joining us. I will now turn this over to Matt St. Pierre with the National Council.
Yes, hi everyone. Thank you so much for joining us. We have a fantastic presentation today. Like Paige said, my name is Matt St. Pierre. I'm a director here at the National Council, and it is my pleasure to introduce our speakers today. Presenting today, we have Keisha Pitts, who is the Director of State Advocacy and Policy at the National Council for Mental Wellbeing. We also have Becca Farley-David, who is a Senior Advisor of Public Policy and Special Initiatives, also at the National Council for Mental Wellbeing. And we're thrilled to have Andrea Richardson, CEO of Blue Bonnet Trails Community Services. Please be sure to utilize the chat for any questions that you might have during the presentation. We will have a moderated Q&A as part of this presentation when the presenters are done speaking. If you do put a question in the chat, we ask you please put what state you're in, because things can vary by state. That'll help our presenters best answer your question. So with that, I will hand it off to Keisha.
Good morning. Thank you for that intro, Matt. So, 11 months ago, first of all, let's advance the slides, please. All right, there we are. Perfect, thank you so much. So 11 months ago, so many of us were anxiously awaiting the official transition to 988 and its potential to strengthen access to crisis care. We know that the full vision of 988 and ensuring a robust crisis care continuum includes many elements, and this isn't going to happen overnight. This morning, I'm going to provide an update on 988 implementation across the states. But first, I want to start off with a little timeline to give the background on the 988 Suicide and Crisis Lifeline for those that may not be familiar. So you take a look at this little timeline here. It shows sort of our path since 2020. And a number of federal changes related to the existing National Suicide Prevention Lifeline began rolling out in 2020 with the goal of establishing a universal, easy to remember 3-digit number to improve access to suicide prevention and mental health crisis support services. In the fall of 2020, the National Suicide Hotline Designation Act designated 988 as the new National Suicide Prevention and Mental Health Crisis number. This replaced the 10-digit number, and the goal was for it to be really easy to recall in a time of crisis and to help increase access to crisis resources. The Act authorized states to create a fee on phone lines that would support 988 related services and allowed states to use the funds collected under the fee to pay expenses that the state expected to incur related to ensuring efficient call routing to the crisis centers, adequate staffing, and the provision of acute mental health crisis outreach and stabilization services directly responding to the hotline. With a go-live date of July 16, 2022, planning activities soon began with telecommunications providers working to make network changes to ensure calls and texts could connect to 988. States also began planning activities, with several states enacting study bills to begin evaluating their preparedness to implement 988. In 2021, the federal government made funding available to support 988 implementation through the American Rescue Plan Act. This included $105 million in planning grants to states and territories. Last year, additional funding for 988 was included in the Bipartisan Safer Communities Act and the FY23 Consolidated Appropriations Act. Beyond grant opportunities for 988 capacity building, additional federal funding for crisis services was made available, including planning grants to expand community-based mobile crisis intervention, as well as an 85% Medicaid FMAP for community-based mobile crisis intervention services, expansion of the Certified Community Behavioral Health Clinic program, and the Mental Health Block Grant Crisis Set-Aside. So on July 16th, 2022, the NSPL officially transitioned to the 988 Suicide and Crisis Lifeline, with call, text, and chat options available to connect with trained crisis counselors. During the very first week, Lifeline saw a 45% increase in volume over the previous week. Recent data comparing May 2022 to May 2023 volume shows an increase of 74% more contacts answered. These contacts often represent a first point of entry for individuals that may require additional crisis services. As such, 988 serves a critical role in the broader crisis care continuum that ensures individuals have someone to talk to, someone to respond, and somewhere to go. Last month, HHS and SAMHSA announced 3 new funding opportunities totaling $200 million for states and territories, tribes and tribal organizations, and Lifeline Crisis Center follow-up programs for post-contact support and linkages, enhanced coordination of crisis stabilization services, and improved connections for high-risk populations. Next slide, please. In preparation for the July 2022 transition, and since the implementation, states across the country have enacted legislation to implement 988 and strengthen their crisis response systems. This wonderful map maintained by NAMI shows the landscape across the country of state legislative action to support 988 crisis response legislation. The status in a few of the states here has changed since this slide was created, so I do apologize for that. But the gold states reflect states that have implemented comprehensive 988 legislation. For the purposes of this map, legislation is considered comprehensive if it includes major components of the 988 model state legislation, including providing for sustainable funding, defining 988 services and minimum service requirements, establishing a 988 trust fund, and addressing system oversight. Following the enactment of the National Suicide Hotline Designation Act in the fall of 2020, several states introduced legislation immediately that next session in 2021 to begin 988 implementation. That year, 4 states enacted comprehensive 988 bills. That was Colorado, Nevada, Virginia, and Washington State. Last year, California enacted comprehensive legislation. And 2 weeks ago, Minnesota's governor signed a comprehensive 988 bill into law. So Minnesota is actually now gold instead of light yellow. And currently, Pennsylvania and Delaware have comprehensive 988 legislation pending. So some of the states that are reflected here in light yellow have actually adjourned legislative session and the measures are no longer pending. Although only 6 states have enacted comprehensive 988 legislation so far, another 13 states actually attempted to advance comprehensive legislation. Next slide, please. Whether states have enacted comprehensive or partial 988 legislation, there are several common components that states have included in 988 crisis response measures, and a few of those are listed here. So 29 states have enacted legislation that includes funding for 988 crisis response. Of course, as I just shared, we know that there are now 6 states that have enacted a fee, and these range from 8 cents to 40 cents. 13 states have established trust funds, so we're now including Minnesota, that's not reflected on the slide. 9 states have established an advisory body, again, adding in Minnesota here. We're now up to 8 states that have addressed insurance coverage. 13 states have strengthened mobile crisis teams, and 36 states had existing programs prior to 2020. These numbers reflect changes since 2020, and many of those states have allocated additional funding to expand and enhance mobile crisis response. 8 states have strengthened crisis stabilization services. And there we had 35 states with existing programs. And again, many have allocated additional funding for these services. And finally, 24 states enacted new legislation requiring student IDs for middle and high school students to include the 988 Lifeline phone number. Several states also require that number to be included on student IDs in higher education as well. So several states have or are currently also conducting studies, and state legislatures have requested agency reports on estimated costs as well as recommendations as they continue to evaluate ways to strengthen crisis care. My colleague, Rebecca David, is now going to talk about the many roles certified community behavioral health clinics can play.
Thank you, Keisha. Thank you so much for that really comprehensive overview of where states stand around their implementation of crisis response legislation. I feel like I learned something new from you every time I hear you present. And as you all can see from Keisha's remarks, there really is strong and sustained attention on 988 implementation all across the country. And I'm sorry, we can go to the next slide, please. And in those conversations about 988, what we're seeing in many ways is attention being given not just to the 988 call centers and their implementation and sustainability, but also to the entire crisis continuum. And that arises, I think, from a recognition that investments are needed, not just in call centers, but also in all levels of crisis response, and that those services do need to be coordinated across the continuum. So the CCBHC, or Certified Community Behavioral Health Clinic model, holds promise for helping states and communities build out crisis response in a way that both aligns with and also complements their 988 rollout. And depending on how that CCBHC model is implemented, it can also bring the potential for additional enhanced federal funding to states and communities' crisis response efforts. The CCBHC model holds the potential to fill gaps in communities' crisis response continuum by virtue of the payment model that accompanies it. It has the potential to be one of what are several necessary tools in alleviating the workforce shortage. It can provide sustainable reimbursement for crisis activities that are built into the CCBHC's scope of service. And it can help states as they're working to establish a standardized delivery structure and bring quality reporting to bear and accountability. I'll pause for a really brief moment to explain what the CCBHC model is. I'm guessing that that most folks are familiar with it, but just to make sure we're starting the conversation on level ground. Certified Community Behavioral Health Clinics began as a demonstration program in 2017. The CCBHC model establishes comprehensive certification requirements that span many domains of clinical operations. Taken together, those requirements are intended to establish CCBHCs as comprehensive outpatient providers of mental health and substance use services that are linked and coordinated with a multitude of other types of providers across the healthcare and social services spectrum. There are requirements related to quality reporting, timeliness of access, and much, much more. We'll talk in a moment about some of those specific requirements as they pertain to crisis care. And in return, organizations that meet those criteria and are certified by their states can participate in a payment model in which the payment for services reflects the cost of delivering them. And so that addresses a decades-long shortcomings in financing for the continuum of mental health and substance use care. And it positions providers to expand services, increase their workforce, and really improve the quality of care in ways that are not always possible under traditional financing streams. So I'll pause there. I am seeing some questions coming in about how CCBHCs alleviate the workforce shortage and more. I'll try and weave those answers in as we go. And then I know we're also going to have a Q&A session at the end. Next slide, please. So, I want to call out a few features of the CCBHC model that make CCBHCs ideally positioned to provide crisis response services and or to partner with crisis providers. CCBHCs are required to serve everyone in need of behavioral health services, regardless of age, ability to pay, diagnosis, place of residence, or anything else. They have to meet timeliness of access standards. That includes being able to provide immediate response for crisis needs and access within 1 day for urgent needs. Urgent needs are different from an immediate crisis. So for an immediate crisis, mobile response should be on the scene or intervening within the timeframes you see here on the screen. But an urgent need wouldn't necessarily rise to that level of emergency, but would require very timely access to services. And so CCBHCs are required to be able to provide that access within 1 day. I will say that as we look at data from the CCBHCs around the country, by and large, they have implemented or are moving towards same-day access models across the board, which is just really helpful in general for getting people in when they need the care, so that they're not left, to deteriorate in the absence of any intervention or support. CCBHCs are also required to provide either directly or through a partner, which is known as a designated collaborating organization, or DCO, an array of crisis response services and supports, and that includes 24/7 mobile crisis and crisis stabilization. And we'll talk more about their, we'll go into more detail on those service requirements shortly. Next slide, please. CCBHCs are also required, so in addition to either directly providing or partnering with a DCO to provide crisis services, they also have to partner and coordinate with other entities that are involved in crisis response. So that might be law enforcement, it might be emergency departments, there might be other types of entities or providers in your community that are involved in crisis response, and CCBHCs are required to conduct a needs assessment, helping them to identify what that landscape is, and then establish partnerships with those other groups or agencies in order to make sure that they are coordinating care and ensuring access for people who are experiencing a crisis. So there's a lot of diversion efforts, for example, happening between CCBHCs and their law enforcement partners. A lot of coordination around care transitions happening between CCBHCs and emergency departments, and many other initiatives designed to help make sure that during or after a crisis, the person is getting access to the mental health and substance use care they need in order to mitigate the effects of the immediate crisis and then help prevent them from experiencing another one. CCBHCs also have to provide a comprehensive array of outpatient services that are designed to engage and support individuals with serious mental illness and serious emotional disturbance, as well as people with substance use disorders. So again, that speaks to that ongoing care and support that is needed to help someone from experiencing another crisis. And as we look at the CCBHC model, I mentioned that CCBHCs have all of these requirements they have to meet, and in return, they get access to a source of funding that that helps them deliver those services. I want to make two comments about that financing mechanism right now. One financing mechanism is through the CCBHC demonstration. And that, again, is a federal Medicaid demonstration that comes with enhanced federal Medicaid funding for states that are participating in the demonstration. And so bear in mind that, that demonstration opportunity is bringing with it increased federal Medicaid funds to support all of the rollout of CCBHCs and the crisis services and the coordination that they engage in. That demonstration is currently live, or Yeah, there are 10 states to date that have been selected for the demonstration and participated in it. 10 more states will be chosen to be in the demonstration beginning in 2024. And there will be opportunities for all states to join the demonstration, with that being phased in every 2 years, 10 more states being able to join. The other financing mechanism for CCBHC is through a grant program administered by SAMHSA. That's the CCBHC Expansion Grant Program. And the expansion grants are a way to invest funding in individual clinics that are preparing to take on all the activities and responsibilities of a CCBHC. And the grant funding can be a really helpful way for organizations to start up their CCBHC activities, or to enhance and expand their CCBHC activities if they've already been certified by their state. So, bear in mind that grant funding, it's a grant, it's time limited. The funding is, it's capped at a certain amount, but it can play a really helpful role in supporting and complementing the Medicaid implementation efforts that are happening within states as well. And I'm happy to take questions about the state landscape around CCBHC implementation. So please put those in the chat or hold them for the Q&A. Okay, so now that we have an idea of how the CCBHC model is financed and what sorts of federal funding are coming into states and communities to help with the CCBHC rollout, let's move to the next slide, please. And we'll talk about what is the actual role of a CCBHC in the crisis continuum. So the CCBHC criteria that have been promulgated by SAMHSA require that CCBHCs conduct a variety of activities and provide services targeted at prevention. So CCBHCs are held to account for engaging people in care, doing so early before their conditions worsen. They are responsible for supporting clients with crisis prevention and planning, and conducting outreach and support outside the clinic, because we all know that people have needs in between appointments, and have to be able to connect with someone when and where they need it in order to prevent a situation from escalating. CCBHCs are also required to directly deliver crisis response. They have to make sure individuals in their service area have access to 24/7 mobile teams, crisis stabilization, suicide prevention, ambulatory withdrawal management, and, as I mentioned earlier, coordination with law enforcement and hospitals. And again, I just want to reiterate the point here that CCBHCs are not intended to replace or duplicate crisis infrastructure that already exists in their community. To the degree there are existing crisis response networks within communities, CCBHCs can partner with those entities to essentially have those organizations deliver crisis care, kind of on the CCBHC's behalf. And then there's a very integrated relationship and coordinated relationship between those entities, so that CCBHCs are able to wrap around the crisis response with a full array of other services that people might need. And so CCBHCs are required to provide post-crisis care as well. They have to engage in discharge and release planning, support, coordination, and again, as mentioned earlier, comprehensive outpatient mental health and substance use care. So ultimately, what the CCBHC model offers is a comprehensive array of supports that can interface with or interface or build upon states' crisis response networks at any point along the continuum, and ensure that there are standardized, comprehensive services available to everyone, held to account for certain quality measures, and universally accessible across CCBHC's service area. Next slide, please. Although crisis call lines are not a required CCBHC service, most CCBHCs do provide call lines. About 64% operate a 24/7 crisis call line that is available to anyone. Others operate call lines that are maybe not available 24/7 or available only to their clients. And then others refer individuals to a crisis call line operated by another provider in their community. So you can see here the opportunity for CCBHCs to either be that call line responder or perhaps be a backup to the 988 call line. You're going to hear more about that from Andrea in a few minutes. But we do have widespread use of call lines among CCBHCs. Next slide, please. And I think where we've seen even bigger gains is in the availability of mobile crisis and crisis stabilization in communities served by a CCBHC. And so this data is drawn from the National Council's annual CCBHC Impact Survey, where we asked respondents, do you provide crisis stabilization and mobile crisis? And do you deliver that directly, or are you doing it in partnership with an existing crisis provider in your community? And so around 3/4 of CCBHCs say that they are providing mobile crisis response and crisis stabilization directly. And about 1/4 are partnering with other organizations to provide. So, we view this as indicative of the expansion of mobile crisis and crisis stabilization services across communities. Many CCBHCs added these services as a direct result of becoming certified. You can see here just about half added those services as a direct result of CCBHC certification. And that, I think is really indicative of the overall expansion of access to these types of crisis response across the country. Next slide, please. CCBHCs are also engaging in other types of crisis response activities that are maybe not strictly required, but are really important innovations or interventions that help them make sure they are doing the best by their clients when it comes to helping people who have experienced or are at risk of experiencing a crisis. Almost universally, CCBHCs are offering post-crisis wraparound services to facilitate linkage and follow-up. Many of them are partnering with call lines to take referrals for non-urgent or post-crisis care. We didn't cover this in the survey, but among those who maybe the third or so that didn't indicate they're partnering with call lines to take referrals, I think in most cases that's because the CCBHC itself is offering the call line. So it's not really a partnership model in that case. We're also seeing CCBHCs engaging in co-response models with police or emergency medical services. And in some cases, in some communities, the CCBHCs are engaging in response instead of police and EMS. So having relevant emergency calls routed to them where a behavioral health team can respond instead of law enforcement. CCBHCs have also opened drop-in crisis centers and other similar crisis stabilization facilities. And let's see, and partnerships with 911 are also quite common. And again, these activities are supported by the special financing that CCBHCs get, either in part from the grant, but really even more comprehensively through that participation in the Medicaid demonstration, where they get access to an enhanced cost-related Medicaid payment rate that supports their full cost of engaging in activities like this. Next slide, please. Okay, so let's stop now with all the sort of the theory of what is CCBHC, and let's make this concrete. So I want to walk through how a person might experience a call to 988 and that connection to a CCBHC. In last year in FY22, the Lifeline received about 4 million contacts. That is a massive increase from the 46,000 calls that were received in 2005. So you can see really the tremendous growth in the utilization of the Lifeline. People who call the Lifeline are given 3 options. They can be connected with the Veterans Crisis Line, they can go to the Spanish subnetwork, or be connected with LGBTQ+ support. And in Washington State only, there's the ability to be connected with the Native and Strong Lifeline. or callers can remain on the line and be connected to a local crisis center. If a local crisis center is unable to answer, the caller is routed to a national backup center. And you can see here, the Lifeline utilization includes 2.9 million calls, just under 1 million chats, and about 0.2 million texts. So people who call or text or chat, people who text or chat the Lifeline are currently connected to crisis centers that are uniquely equipped to respond to texts and chats. So you can see here how, the website and the number that you use to text or chat. And the important point that I want to emphasize here is that the majority of call centers are providing follow-up care, and all call centers are providing resource connections based on community options and the availability of resources within callers' own communities. So call the Lifeline, this is what you get. And let's move to the next slide, please. And so how does CCBHC fit into all of this? There's really 3 sort of broad models for how CCBHCs can interface with 988. The first is for CCBHCs to be 988 call centers. CCBHCs can also provide crisis support services that are not delivered directly by 988 call centers, and they can be referral partners for post-crisis or non-urgent needs. In the Medicaid demonstration, states, this is really important, the states get to define how the 988 and CCBHC partnership works. So there's tremendous flexibility here for states to design their CCBHC models in a way that aligns with and complements what they're doing around 988 currently. In areas where states are not driving CCBHC implementation through Medicaid, grantees, of course, are required to have those partnerships with 988. But we're really going to focus on what states can do to formalize the partnership between CCBHC and 988 and integrate CCBHC into their crisis response efforts. Next slide, please. Okay, so let's dive into that first scenario. CCBHCs are the 988 call centers. So in this scenario, CCBHCs receive and respond to 988 calls. They're part of the National Suicide Prevention Lifeline Network. They, as any call center would do, they triage callers, they address needs that can be met on the phone. If the needs can't be met on the phone, they ensure access to higher intensity services. And those higher intensity services could be provided directly by a CCBHC or by a DCO partner. And they coordinate with their partners across the continuum to ensure that callers are connected to care. CCBHCs would then ensure access to post-crisis follow-up care with the CCBHC, or they could coordinate with callers' other care providers for any necessary supports. So in this scenario, CCBHCs are really the full service provider. They receive the 988 calls, they're out there delivering mobile crisis if needed, and crisis stabilization, and then they're offering that connection to post-crisis and ongoing care to make sure that people's needs are fully met. So this is one model. Next slide. Yep. The second model that states could choose to adopt is having CCBHCs as crisis provider partners. So in this scenario, the CCBHC might not directly receive 988 calls. Maybe they're not part of the Lifeline. Maybe they are part of the Lifeline, but they're a backup center, so they're not getting most calls. So the CCBHC's primary role is not as a call center, but they do fill other gaps in the crisis response continuum. So the 988 call center might have a partnership with the CCBHC, and when an individual who calls 988 is in need of mobile crisis or crisis stabilization and so on, the CCBHC gets called in at that point to deliver those services. And once again, this is the theme you're going to hear from me over and over. The 988 call center and CCBHC are responsible for coordinating with each other to make sure callers are connected to the right care at the right time. And once again, CCBHCs in this scenario would also be ensuring access to post-crisis follow-up care with the CCBHC and coordinating with callers' other care providers. Next slide. And the third model would be CCBHCs as post-crisis referrals. This would be the model states might use if the existing 988 call centers and crisis response network are taking on the full continuum of crisis response. They don't need a CCBHC to come in and deliver mobile crisis, crisis stabilization, and so on, because they are already doing that. And as I mentioned earlier, CCBHCs are not meant to replace existing networks. They're meant to complement those networks. And so in this case, the existing crisis network would be considered a DCO, a designated collaborating organization, and they have a partnership with the CCBHC to make sure that that the CCBHC is available to those individuals for post-crisis support, for ongoing services, and again, for coordination with other providers, including the crisis network. Next slide, please. So to summarize, the CCBHC model offers an avenue to build out and invest in crisis continuum capacity. That avenue is flexible. It can work with states and communities to meet their needs and acknowledge existing capacity and infrastructure within those states and communities for crisis response. There are multiple financing sources that may be available to support CCBHC's crisis system investment. And states that are currently working on or intending to pursue CCBHC implementation, we would very much encourage them to build CCBHCs into their thinking on crisis system development. So many areas of alignment and synergy here. And in all of this, cross-agency collaboration is critical. Collaboration between the folks within a state working on 988 and crisis systems, collaboration between the folks working on CCBHC, and of course, all the other agencies and providers that, that touch people's lives in a moment of crisis. So with that, I'd like to close my comments and turn things over to Andrea, who's going to give you a perspective from on the ground.
Good morning, and my name is Andrea Richardson. I am the CEO for Bluebonnet Trails Community Services. We are a CCBHC in Central Texas. And Rebecca, I thank you for that introduction, and to you and Keisha, great job laying out the groundwork about certified community behavioral health clinics. First, I want to offer our best wishes for all of our friends in the North and the East, Northeast about the smoke that you are experiencing. Please know in our area, we're experiencing some bandwidth issues, so I ask your forgiveness of turning off my camera to present. And with that, so that I can make sure the audio stays intact, I want to be reminded about the amazing things that have happened across this nation and who all we need to thank. Of course, for the legislation that presented this, our national partners, SAMHSA, NASHBID, and the National Council, you have led the way with this effort. And in Texas, because we will be talking about the Texas model, we have some exceptional partners. We have our Texas Health and Human Services Commission, who not only directs our 988 response, they walk alongside us every step of the way to make sure that we get it right. And when we look at metrics, it's metrics for all of us, not just for the accountable CCBHCs and partners deploying the effort. We also thank our Texas Council of Community Centers, who is our experts in policy development and makes sure that we are all together in a, as much as possible, standardized approach to care. Please note that our goals that we are seeking to fulfill in the state of Texas are threefold. We are looking at access to care, timeliness to care, and also we are seeking to annihilate stigma. For the previous two, for access and timeliness, we're looking at two metrics, and you'll see those peppered throughout this presentation. First, we're looking at an in-state answer rate to achieve by April 2024 of 90% answer rate. That's an in-state answer rate so that the calls do not roll over to an out-of-state call center. The second and third things that we're looking at are the speed of answering the phone calls so that a person is not waiting on the line, And the third thing is really a focus on the follow-up connections for individuals to ensure they don't fall through the cracks and making sure that they are well connected into care. Next slide, please. And so in Texas, our Texas model was adopted by our Texas Health and Human Services Commission under a performance-based contract. And with those expectations of performance, 5 call centers were developed. 4 are certified community behavioral health clinics, and 1 is a volunteer-based organization. Emergence Health Network is out of El Paso, demonstrating Western access. Integral Care is in Austin, Central Texas. MHMR, My Health, My Resources of Tarrant County is our Fort Worth location. Suicide and Crisis Center of North Texas is the volunteer-based organization out of Dallas. And the Harris Center out of Houston is also a flagship center where these 5 call centers are taking the calls to ensure Texans have access to care. However, what we've experienced with our call centers is that we just don't have enough bandwidth to answer the calls. So the Texas Health and Human Services Commission looked for an additional backup answering center so that when the calls could not be answered quickly enough by the 5 call centers, a backup call center would be able to answer on behalf of the primary call centers. And that call center was deployed on May 2nd, 2023. Our community center, our certified community behavioral health clinic, Bluebonnet Trails, is the backup answering center. We are located in Central Texas and serve an area of about just under 7,000 square miles. We are also a mix of urban and very rural areas. You'll notice that the 5 call centers are very metropolitan in nature. For us, we were able to give a bit of perspective from the more rural area. And so there is a very happy and intentional mix in looking at metropolitan and rural access and influences for our 988 call centers. We are looking, as Rebecca has noted, we're looking at ensuring that our certified community behavioral health clinics serve as 988 call centers, that we provide crisis care, and that we're also looking at post-crisis care and follow-up services. So that is the perspective of the state model to date under the CCBHC model. Next slide, please. And so today, community behavioral health clinics are providers of crisis support services. Not only do we provide those services through the 988 call centers where persons are seeking typically emotional support, we're also providers of crisis hotlines and expediting care in our communities in partnerships with others. As a result, we're also connected with many referral partners to ensure that there is timely, ongoing care after the crisis and to also meet non-urgent care. Next slide, please. And the value that community behavioral health clinics as a building block for 988 is very influential. We noticed that for our model, we're there to fill the gaps. We're there to remediate workforce shortages that we're experiencing throughout the nation. And we're also seeking a standardized structure that includes not only delivery of care, but also reporting and accountability. To fill the gaps in the community crisis response system, we are looking at the statewide warm line, and that is through 988. This 988 crisis and suicide prevention warm line allows us to look at services in a very unique way. Typically in the state of Texas, we are known as CCBHCs to deliver immediate care, typically through a crisis situation, and then for ongoing connection to care. So this warm line really gives us an entry point into engagement, early engagement in care that we have not had before in a very structured way. Alleviating the workforce shortage has also been very instrumental in our access to 24-hour crisis workers For Bluebonnet Trails in particular, we have the privilege of partnering with our crisis hotline that has been a longtime partner with our center and there's 27 other centers across the state of Texas to ensure that there was a response. It was a unique way to use as a platform, a system that had the technology and the experience, but also allowed us to have a jumping off point for this. I also want to highlight the quality reporting and accountability. Using Vibrant, the contractor at the federal level, we're able to really get some excellent conversations underway with data-informed structures. We're able to look at tables of comparative analysis over time and understanding which way we may need to pivot in order to ensure that needs are met through the warm line, and then through our own databases to ensure that what we're capturing as an end result may also be addressed. And then finally, making sure that we're looking at resources available in the continuum of care. The resources are very unique in the state of Texas. There are 254 counties that each have 254 unique community needs. Making sure that the CCBHCs that now represent each of the 254 counties have a way to communicate, a way to dive in, and a way to deliver care has been a source that we're really focusing on in the state of Texas for investment in mental health care. Next slide, please. And as we talk about that mental health care, I'm reflecting back on what Rebecca had presented as the three major components of CCBHC. Those, of course, are prevention, crisis response, and post-crisis care. We are going to skip over early engagement for just a moment, but in the state of Texas, we have developed specialty care as a state that did not expand Medicaid in our continuum in Texas. We are reliant heavily upon resources that come through our state legislature, through Medicaid, of course, for those billable services, but also through local means. And it's those local means that really help us engage in prevention, crisis response, and post-crisis care. We're able to look at our integrated health services, making sure that primary health care and access to all avenues of specialty care, including IDD, intellectual and developmental disabilities, early childhood intervention, substance use treatment, mental health, and autism care may all have a way to have a unique assessment, giving the person that we're serving a unique and least complicated experience as possible. We are also looking at crisis prevention planning, making sure that persons that are prone to crisis have a specialized plan in place so that we are not waiting for a crisis to occur, but there's a plan already developed, not only for the individual, but for their loved ones and for our system of care to make sure that person may be wrapped around as quickly as possible. And those wraparound services primarily come from our outreach and support outpatient clinics that really make sure that we have those ongoing points of care for the individual. We also provide jail diversion in many ways with teams outside the scope in outpatient competency restoration. Also through in our outpatient care, we make sure that our efforts are toward jail diversion. Our communication with our law enforcement is also primarily about jail diversion, but we're also embedded in the jails to make sure that assessments may be conducted immediately as soon as they can possibly be after an intake into the jail, so that persons may either be diverted and or we are connected to them throughout the court process. And then, of course, we're very fortunate to have our peer-led care. These include certified peer specialists as well as family partners that may wrap around, giving that lived experience and informed treatment for persons so that they feel comfortable that persons are walking alongside them in care. For our crisis response, we have a vast array of crisis responses throughout Texas. These are not located in every county, but these are some primary ones that we're all striving to fulfill. For Bluebonnet Trails, we're very fortunate to have a 24/7 mobile crisis outreach team and a 24-hour crisis hotline that deploys our team, just like all certified community behavioral health clinics may have throughout the state of Texas. For us, we also at Bluebonnet Trails provide crisis respite services for adults. For the persons over 18 that are experiencing a short-term crisis, we want to make sure that we're offering respite so they may recover quickly through a team of experts and return to their home community, fulfilling their dreams and thrive along those persons in their community. We're also fortunate to have a youth respite program, which is very therapeutic in nature, serving children from the ages of 5 to 17. Without a regard to diagnosis, they may come to us from the Department of Family and Protective Services and Child Protective Services in the state of Texas, or they may come from an independent school district we're working with. The intent is to make sure community partnership is there so that children and adults may receive these services as quickly as possible. We also provide extended observation and crisis stabilization to ensure that there is an opportunity to make sure persons with mental illness or have those advanced needs prior to having to admit into a private psychiatric hospital or into our state hospital systems in Texas. We also provide substance use withdrawal management. We uniquely have diversion centers in Texas, and these are exceptional partnerships with our local communities where law enforcement is able to triage an individual experiencing a crisis in the community and dropping those persons off at our diversion centers that are open 24/7 and able to receive a person so that the law enforcement agent may go back into care into their community without regard to having to come back to the diversion center to transport the individual into an appropriate level of care. For us, our diversion center is a pivot point where we're able to triage either to step the person down into less intensive care after an assessment, evaluation, and perhaps some medication management. But service coordination and care coordination goes on from the point we receive the individual to ensure the team is working together to step a person down into care, or if needs require, raise them up into a private psychiatric hospital bed or more intensive level of care, including the state hospital system. As Rebecca also mentioned, 911 dispatch is an amazing opportunity to build those local partnerships. When a caller is contacting 911, they are advised of, are you seeking care through fire, ambulance, police, and now mental health. When they add mental health, we are quickly added to that call so that we may triage the call, may in the background connect them to our mobile crisis outreach team or law enforcement officer in our community, which in our case might be a certified a crisis intervention team member, or it may be a mental health deputy to engage with that person should that level of need be there. We're also part of a co-response with our EMS systems, our emergency medical services in our systems throughout our communities. In one of our counties in particular, we do a co-response where we are very involved in Narcan distribution. So not only is our mobile crisis outreach team deployed, we also have our substance use providers expert in the delivery of care to be provided alongside our EMS systems. When we focus on post-care, we're looking at care coordination. This is an exceptional thing that has grown over time. So often we had equated this with case management through the Medicaid systems, and it is so much more than that. Specifically, this allows for very unique resources to be available not only internally to our system of care at Bluebonnet Trails, but also externally. They are the experts in understanding the resources available in our communities. We are referring out to partners that are being developed over time. And so that knowledge base that our care coordinators have of these resources has benefited not only the persons that are experiencing a mental health crisis, but those who just are seeking care in our community, as well as those persons who may have co-occurring disorders, including intellectual and developmental disabilities and substance use treatment needs. These are experts that really they're the linchpin of our system through our certified community behavioral health clinic. And without them, we would not be able to have the level of response, the robust response we have from our crisis services and transition into outpatient care. Also highlight the comprehensive outpatient mental health and substance use disorder care throughout the state of Texas. We're very fortunate that as CCBHCs, we are required to provide both, and it certainly has been a benefit as a building block for 988 through the state of Texas. Our state hospital step-down programs are a pilot in the state of Texas. The state hospitals in Texas have had a very high increase of forensic patients in what had usually been a vast majority of civil patient admissions. So as the forensic admissions are taking the capacity at our state hospitals, a plan was developed for a pilot to have an intentional step down of persons that had a length of stay of over a year in our state hospitals, to bring them down to have an intensive wraparound team that allows for a community transition for these individuals. These are conducted through interview processes with our state hospitals across the state, as well as those individuals who may benefit from this care. So the state hospital systems opens capacity in our systems. Those step-down programs open that capacity, but even better, they utilize the Certified Community Behavioral Health Center principles of connecting into the community care chosen by the individual. So we are not keeping these individuals in Central Texas. As a matter of fact, only a few of our graduates have been kept and have chosen Central Texas as their home. Our care coordination team is coordinating with CCBHCs throughout the state of Texas to ensure there is linkage for those persons when they graduate from the state hospital step-down programs. And then, of course, forensic aftercare programs. As persons leave the jails, go through the court systems, we are engaged at those points in our jails and in our court systems so that we are able to inform the courts about the opportunities for persons who are leaving the jails, so that judges may conduct court orders for care. And so it may or may not be within the CCBHC, but our care coordinators are able to grab a hold of that plan and work alongside the judge and our attorneys throughout the court to ensure a plan may be developed for the person who is then responsible for communicating with the court upon release. So these are great ways to make sure that the CCBHC role is highlighted. But I want to turn your attention to the highlighted box for early engagement and bring us back to the 988 conversation. Typically, for our community center, our early engagement had been through our appointment and information line or through our crisis line. 988 offered us a very specialized way to have a person seeking emotional support, to give them early access to care, and also to ensure that there wasn't that hesitation that is typically associated with the stigma of reaching out to a public certified community behavioral health clinic. And this allowed a person's freedom through 988 to engage with us, and knowing that there was continuous care that could be there should they need that extra care. Those emotional supports offered by 988 have been exceptional. Next slide, please. And diving deeper, of course, we need an acronym for our system of care, and that is KPI, our Key Performance Indicators. I mentioned previously that Vibrant has been the contractor selected for this rollout of 988, and they have done exceptional work in making sure that not only are we joined through technology, but that we are joined and learning through data. This is a presentation of data that has been provided by Vibrant to the community centers This is a broad a review of the state of Texas that gives you some information about our month-to-month calls, allowing you to see kind of some growth rates for those key points that Texas is seeking as goals. One, looking at the in-state answer rate, making sure that we are progressing toward our goal of 90% by April 2024. We also look at the in-state abandonment rate. This tells us that we need, where we need to stand to ensure that we answer those calls as quickly as possible so persons aren't abandoning the calls by waiting on the line too terribly long, especially as they're seeking emotional support. And then as the backup center for Texas, our eyes are on the blue shaded area that flow out to the backup centers to make sure that we are addressing those calls as quickly as possible. We're also looking at the rollover rate to make sure that our primary centers have those strengths that they need in order to answer the calls as quickly as possible, but knowing that where there's safety net should that call that they're on with an individual need extra time, we want to make sure that they stay on that call and the backup center will answer the calls. And then for the convenience and for the just comfort of the person's calling, our eyes are on that answer, the average speed to answer the calls. Next slide, please. As always, we are trying to advance the knowledge of 988. Of course, the soft launch occurred on July 16th. Excuse me. We are trying to advance this through many partners. NAMI, the National Alliance on Mental Illness, has been an exceptional partner in ensuring that we had a way to roll out information to persons. They are very clear in this. That is very family-friendly language. It tells them what to expect rather than to say when you're in crisis. It tells them, this is just that comfort zone for you so that you know that this is confidential and that we want to make sure you know how it works and what to expect. The communication through 988 is going to be critical. We also know that when communication is really through a full launch, we are going to be expecting our metrics and our data to really reflect that additional rate of call, as truly will happen across the nation. I want to bring your attention, however, to the yellow highlighted area. This response in the state of Texas indicates that some communities, that the crisis line may be able to connect you to additional services or follow-up, but it's clear to state that not all communities have this capacity. So the next slide, please. So for persons who understand that they may not have a full capacity to all services, this is a critical point that we are collecting data on as well. We're trying to identify those services that persons have indicated may be helpful to them so that we can fill the gaps within our system of care through some strategic planning, if it's local, if it's regional, or if it's throughout the state. So this key component about recognizing that not all communities have the capacity to serve in the same way as others is going to really provide us not only communication to the person's calling, but also opportunities to make sure that we are following up on those gaps, ensuring that there are connections to available services throughout. We're also looking at those referral points that are within the CCBHC, but also outside that system of care to ensure that follow-up contacts and referrals may be made. And then, as always, care coordination is that point that allows us to ensure a connection is made for the follow-up to the requested care. Next slide, please. To give you a little bit of detail with regard to how Texas is viewing these metrics, I wanted to bring your attention to this slide that shows our answering rates through 988. This demonstrates with the bars, these are the 988 calls that are received, and the green line is indicating the call center answer rate. You're seeing that we're progressing. You're seeing that we had a dip as we were rolling out and understanding how we might, in the state of Texas, respond to these calls. But if you look at the point between September 2022, when we were officially rolling out, to that point in April, which is our latest data received from Vibrant, you're seeing a steady progression of our ability to respond to those calls through our in-state answer rate. So we're applauding the efforts of our primary call centers, and we're grateful now in the month of May that the next metrics will demonstrate how the backup center has made a difference in these calls. Next slide, please. I think it's also important to notice, Keisha and Rebecca have noted, that there's a local impact with 988. And as Rebecca had mentioned, our response for crisis services has certainly been impacted. During the soft launch period, there was a rise in mobile crisis outreach activations by our CCBHC, and we are really monitoring that to understand what those activations may be. We're trying to ensure that these were accurately deploying our mobile crisis outreach team, and that we are really effectively making sure that there's a communication and a connection about what constitutes a deployment of mobile crisis outreach versus what may also be a way to re-emphasize and refresh what we're doing through the call center. That may come in the form of some specific counseling, some specific training we may need for our 988 centers. But in addition, it also is reflective of that community response once that call ends, how that person is referred to us and how we are activating our response. So on this slide, you're seeing the bars are the calls that are being received through 988 by our community center. It also indicates that the mobile crisis activations by Bluebonnet Trails, our CCBHC, have increased over time, especially since the soft launch in July. We're watching these numbers to make sure that we have the right staff in place, that we have communication done as quickly as possible, and that we have partners in place to ensure that we're able to hand off persons as quickly as possible so that they are not retaining a mobile crisis outreach member who may need to be redeployed, but that we are wrapping around them with that care to ensure there's follow-up, to ensure that there's an activated plan in place for the individual, whether or not they are engaged or admitted into the care of our CCBHC. Next slide, please. This is also indicating that we are increasing that availability of mobile crisis outreach. For Texas, we are looking at the time-limited funding through SAMHSA grants. Again, we are not a Medicaid expansion state, so we have been heavily grateful, but also benefited from the SAMHSA grants in order to ensure the response that we have been able to sustain to date in Texas may be there as a CCBHC. We have a braided funding stream to sustain our CCBHCs, and that includes the Texas Health and Human Services Commission, our performance contracts through the agency to ensure our services are in place. We also have local support through counties and health districts and cities supporting our systems of care. And then, of course, we have grants that allow us to specifically provide crisis services, as well as support us in making sure that there's a continuum of care for those individuals seeking care through the public community behavioral health clinic system. And as we have a legislative session underway in Texas, we also are very fortunate that our legislature is focusing on mental health. Specifically in Texas, they are looking at how to sustain the local crisis response through multiple ways. They're adding dollars through our base budget in the state of Texas that focuses on crisis services. But even more importantly, to address local needs, the legislature has driven a response through this and directed Texas Health and Human Services Commission to initiate competitive application processes. These competitive applications allow certified community behavioral health clinics to apply for funding given a narrative that identifies the specific needs in our communities. This is a brilliant way to make sure that we have a local response to local needs. And so not only is there statewide expectations and funding, we're able to address specifically local needs through the competitive application process. Next slide, please. In conclusion, I just want to highlight how increasing access to community-based care has been deployed not only through CCBHC models, but also through 988. We've offered cross-agency collaborations. These come in the form of not only through our Texas associations and our national associations, we raise up our local systems. That includes specifically our law enforcement, emergency medical services, 911, our court systems and our jails. Each of these components, along with our ISDs and partners, our nonprofit partners, really have a voice in this collaboration. Not only a voice, but they have a specific part that make us all stronger in our communities. The public-private partnerships are also critical to our care. Private psychiatric hospitals and general medical hospitals that afford an emergency department have been instrumental in communicating with us. They have identified gaps for us and with us so that we can ensure that we're meeting those emergent needs in our communities. But more importantly, they seek to make us stronger. We do not have those relationships that, or our sector does not have those relationships that are condemning. They are more, how do we make this better? And I think that that has been afforded through the collaborations throughout our local area. And in addition, we are always looking forward to regional approaches with our sister community behavioral health clinics, as well as for specialized care. We steal great ideas all the time, and we are very fortunate to have a robust system of CCBHCs throughout Texas that informs our ability to steal. We are also, as a system throughout Texas, we look for those catalysts for innovation. We are not always interested in just kind of retaining that same old. We are looking for valued partners around the table to have a voice in what's next, but specifically to look at what's worked across the state and how do we make sure that it can work and address the specific needs in our area. So with that, we're looking at making sure that through this National Council conversation, we thank everyone for your insights on this. And I know that Matt is going to lead us through a question and answer period. So I'm looking forward to your questions. Thank you.
Yeah, thank you to all of our presenters for all of that incredible information. Very informative. The chat has been very, very active with questions for our presenters. So we will start taking some questions. So Becca, I know that you addressed this a little bit in your part of the presentation about how do CCBHCs alleviate or help alleviate the workforce shortage. I wasn't sure if there was anything else you wanted to kind of underline or highlight about that. That was a question from Clarence.
Sure, happy to say a little more, Matt. So for CCBHCs that are participating in their state-driven implementation of the model, so remember that's the financing model where CCBHCs can receive payment through Medicaid that is calculated to cover their cost of services. Those CCBHCs are able to aggregate costs of delivering care across the board, including things like staff salary costs, including things like hiring additional staff, and including things like hiring staff for non-clinical functions that don't typically draw down Medicaid reimbursement. The costs of all of those things go into the payment rate that those CCBHCs receive in the form of a prospective payment rate. And so if you need to raise salaries in order to recruit staff, if you need to hire types of staff that your financing has not previously supported, like additional psychiatrists, additional prescribers, and if you need to hire staff for non-billable functions, all of those expenses are reflected in your payment rate, which then can support you in the cost of taking on staff, improving recruitment and retention, and more. And that has been the experience that we have seen across the country, is that CCBHCs have been able to engage in significant hiring and improve retention as a result.
Great. Helen asked this question: what are the considerations of the access standards in the current staffing crisis? That was Helen from New York.
Yeah, I think how I'm interpreting this question is how do you reconcile the nationwide workforce shortage with the fact that CCBHCs have to offer access within certain timeframes? And yes, that has absolutely been a challenge. I think CCBHCs have been moving towards same-day access models that kind of leverage staff in different ways to be able to meet demand where it is. We've seen CCBHCs using telehealth to supplement access as well, and that has been quite successful. And across the board, CCBHCs are really doing well at meeting that 10-day access timeframe. Although, of course, there is no magic wand for the workforce shortage. We are hearing that CCBHCs have strategies and financing at their disposal that are helping them meet these access standards and ensure people can get into care.
And so I want to invite our other panelists, if you have thoughts or want to jump in, please do. I know I put the first one to Becca because it was a little bit in her section, but Keisha, Andrea, please feel free to jump in at any time here.
Matt, may I go
Yeah.
ahead? And I also want to highlight, it's also the DCOs, the designated collaborating organizations. Our partners in the communities remind us that we don't need to do this on our own. So when we work in partnership with other providers, we're able to strengthen that response. We contract with so many systems because we do not have the ability to hire as quickly as possible. And the cost savings that sometimes come with contracts has been very beneficial. So I'd like to highlight those contractors as well as our DCOs.
Awesome. Next question. This was from Toby. Are CCBHCs required to have prescribers for psychiatric medications and/or MAT?
Yes, that's an easy one. Straight up, yes.
Okay, well, we'll move to the next one then. Our next one. Are CCBHCs receiving expansion grants certified by their state? This is from Jonathan in DC.
Yeah, I think that's an excellent question because with the two financing streams, there can be a lot of confusion about what it means to be a grantee and what it means to be state certified. So again, SAMHSA provides grants directly to clinics if they compete right in a grant cycle to win those grants. Receiving a grant does not necessarily mean that you will be certified by your state through a state Medicaid implementation of the CCBHC model. There are currently 12 states that have implemented CCBHC through the demonstration, through a state plan amendment, or through a waiver, as Texas has done. And there are 15 plus more states that are planning and hoping to join the demonstration in the future. So in those states is where the state certification is available. In other states, like Washington, D.C., there is not a state certification available currently. So it really, whether you can get certified by your state will depend on what that state is, even if you have received a grant from SAMHSA. And then some organizations like Bluebonnet Trails have done both.
And I think that's unique. I think every state has its own response. For us, we do not have specific certified behavioral health clinic funding, but we do have those foundational pieces covered through a performance contract through the state agency. So I think it's unique how each state is coming up with the opportunities to ensure funding is there. but also to ensure that collaboration is there at the national level with each state. So again, kudos to the National Council and NASHBID for making that happen.
Well, next question. Are there additional funds to support expansion of services, such as like a CCBHC becoming a call center, or would that come out of existing funds? And this is from Joe.
And Keisha, Rebecca, I'll probably start that off and I'm sure you'll add to it, but this opportunity for Bluebonnet Trails came through the recognition that there was a gap in care. So this is additional funding to be a 988 backup call center, as it is to be a 988 primary call center. So the funding did come through the federal level. It was passed through the state of Texas and was provided through each of those call centers through a competitive bid process or competitive application. So this allowed us to work together in defining a system of care, but it also ensured that there was a funding stream to back up the staff, in our case, 21 call takers that are working in the backup center. And there are approximately 125 other call takers in the primary system.
And I'll add to that CCBHC does offer helpful additional funding for implementation of all the requirements to be a CCBHC, including the crisis response requirements. And again, that funding can come through Medicaid or from a federal grant from SAMHSA, but it does not replace other sources of funding that clinics currently utilize and have access to. So it's a helpful addition. And we would expect that clinics still utilize a wide variety of other funds to provide care to.
Keisha, you want to add anything?
They both said it all. I don't have anything else to add.
Okay. This question came from Paul. What can an in-state call receiver do that an out-of-state call receiver cannot? We were talking about in-state answer rates and the differences between backup centers and in-state. So Paul's wanting more about that.
Since we've had experience with that in Texas, I do want to note, every state is unique. And because those primary call centers that are embedded in your state have the most knowledge, for instance, Texas centers will know the Texas centers and they will know the basic services that may be covered. So that conversation with the caller may be a bit different than someone who may be taking it from California, New York, Rhode Island, Kansas. It's, just that knowledge base and comfort level they can offer the individual because they do have some basic knowledge about the services. And as always, we have our resources at our fingertips so that we know who our friends are to call in each of our states and how we might get additional services and even contact that caller back.
And I'll just add on to what Andrea shared, and that's a great example, and that you all already have that knowledge and you're doing that. But there are also a number of states that actually have state law that require the establishment of these integrated coordination systems, and they are providing individuals that are participating in the 988 Lifeline with sort of this insight information around bed availability or the existence of mental health advanced directives, just real-time information that is available in the state that those out-of-state providers would not have access to.
Okay, next question. Are Texas CCBHCs accepting law enforcement drop-offs and involuntary patients?
I can speak for our center. Yes, we are, with the goal of making sure that our law enforcement agents have that strength and they know that we're wrapping around them to get back into the community. We accept voluntary as well as involuntary. Most persons are coming in with law enforcement. The law enforcement officers in Texas are trained about mental health crises. They are some of our finest experts in sharing with us what they're seeing in the field. So that really matters in dropping that person off. And so those persons do come to us in both cases, voluntary and involuntary.
Awesome. Okay, next question. How does the CCBHC model work in states that already have value-based payment models with their Medicaid program? And that's from Adrian.
Yeah, Adrian, I would say that the CCBHC model uses a prospective payment system, which is in fact aligned with many elements of value-based payment. And really, individual states are going to determine how they want that PPS to, sort of interface or align with existing other value-based payment initiatives. So with 12 states in the CCBHC model, there are 12 different environments, and Texas certainly being one of them. So I don't know, Andrea, if you want to add more to that.
Thank you for that, Rebecca. In Texas, we have Medicaid managed care organizations that are able to provide value-based payments. For us, we have not yet been successful in modeling the CCBHC practice together. We have been successful in doing increments of what a CCBHC does. For instance, our diversion center, we may receive a value-based payment rate for the diversion center activity, but we may not receive it, of course, as a certified community behavioral health clinic. So we are still working on that too, Adrian, and thank you for that question. I think that's something that most states have on their radar that we really want to advance over the years.
Okay. Next question. Clarence asked, is there a well-defined role for peer support services? So wondering if maybe the panel wants to discuss kind of how peer services are integrated in CCBHCs or crisis response.
So as a basic foundational requirement of the model, CCBHCs do have to offer peer services. And I would say, based on the data emerging from the federal government and from our own surveys, peers are one of the most commonly hired types of staff at CCBHCs. And how CCBHCs utilize peer support throughout their programs is really based upon local needs. And CCBHCs are using really innovative approaches to doing this. We work with a grantee in North Carolina that sends a peer along on EMS calls when an overdose is involved, and is there to, figuratively and literally hold the individual's hand, through the overdose reversal process and transport to the hospital and so on. So that's one example. Obviously, each clinic is going to innovate based on their own needs and local capacities. Andrea, I would love to hear how you all are using peers.
This is a favorite topic for us. First we have, we not only have peers for the persons we serve, we also have peers for their families as well as peers for first responders. We make sure that when a first responder is going through something traumatic, we have persons that have experience with fire, veterans, as well as police backgrounds that really go out and connect with our first responders. I highlight that because of some traumatic events that have occurred across the state of Texas over the years. But we also have veterans peers. That is so critical, not only for the veteran, but for the family. So the peers that we have are not only a veteran themselves, they may be a family member of a veteran that may connect one-on-one with that individual. That is so helpful. And I love the example about going alongside Rebecca. For us, that we have not gotten there yet, so you just gave us a point to strive for. We usually receive those individuals. That's one of the first connection points when we recognize who they are. We add that voice into the development of the person-centered recovery plan with the individual so that there may be some leadership along those lines about, this helped me, or have you thought about this? Or I experienced, so-and-so with my child. And especially with children, we have family partners. This is a tremendous service that educates a family, connects the family, is really one of our first lines of defenses to make sure that we're able to capture that family and strengthen and reunify them as much as possible. And what we're also hoping for, along with the ride-along peers, is a youth peer. I think that this is an element that we have missed out on as Bluebonnet Trails. And so we are seeking those youth peers, especially as we've opened our youth therapeutic respite programs. We see the value in watching the children as they've been there for a longer period of time, how they mentor another, how they engage differently than we could ever engage, and give that level of confidence to a youth. So that is what we're seeking next, is youth peers in our area, in particular, not only for mental health, but also for intellectual and developmental disabilities.
Okay, well, we are right at time. I'm going to hand it back to Paige to close us out. Thank you, everyone, for your attention, and to all of our presenters.
Thank you, everyone, again for joining us. I want to thank SAMHSA, the National Council, all of our presenters and our interpreters, everyone for assisting us today, and for all of you for joining us. There will be a survey that'll pop up in your window after the presentation has concluded. If you all could please share your thoughts with us by completing that survey, that would be great. We would truly appreciate it. Again, we thank you all for joining us. Have a great rest of your day.